presence and consequences of cost information in prescription drug advertising. This lecture is about spending on prescription drugs is far higher in the US than anywhere else in the world, due in part to limited regulation of drug prices. In response to ongoing demands for political action, the Department of Health and Human Services proposed a policy mandating the inclusion of drug list prices in direct-to-consumer pharmaceutical television commercials. While that policy has since been blocked by the court system, questions remain as to whether such a policy could still lower drug prices and what unintended effects may arise. The presentation reports the results of a multi-method research project aimed at addressing those questions and tracking cost-related information in TV drug ads over time. A little bit about our speaker. As mentioned, Dr. Ball is an assistant professor in the Department of Advertising and Public Relations here in Klein College. Her scholarship examines the messaging strategies and effects of advertising and promotional health communication with a focus on direct-to-consumer pharmaceutical advertising. She has published her work in a variety of health communication and marketing communication journals, including the International Journal of Advertising, Journal of Health Communication, Journal of Consumer Affairs, Journal of Current Issues and Research in Advertising and Health, and Marketing Quarterly. I should also like to mention that Dr. Ball is also associated with our doctoral program in media communication, and she was one of the architects for a new certificate that we share with public health called public communication. So she worked hard on that too to get that rolling, which actually just started. So a couple little footnotes there in terms of other things she's done at Klein College. So with that, please welcome Dr. Jennifer Ball.
All right, thank you. Let me go ahead and share my screen and hope that I'm sharing the right one. Oh, now I'm a little, okay. All right, is that good? Are you seeing the full presentation of it? All right, we never know in this world. And in listening to that description of this talk, I'm realizing that when I wrote it up in August, I was perhaps a little overly optimistic in the comprehensiveness of results that I'd have ready to share at this point. I am going to be sharing some of the preliminary findings or at a top line level from this research I've been working on, and finding that there's a lot more that we're still very much in the process of looking at. But thank you for everybody for joining in. It's good to see everyone. You know, as I said, I'm going to be talking about prescription drug advertising, which is this fascinating category of advertising that a lot of my work revolves around. My background is a mix of advertising and health communication. And so prescription drug advertising is this perfect blend that continually produces interesting questions for my research. And I always like to start when I'm giving a presentation on this topic with just a little bit of an overview, because I never know how much people know about this category of advertising. It's something that if you have traditional media consumption habits, it's really hard to avoid these ads. Spending on this ad category has been sitting pretty steadily at a little over $6 billion each year for the last few years, which represents a really meteoric rise in the spending on this category over the last couple decades. It is something that the ads we see are only legal here in the US and New Zealand, and even New Zealand, it's slightly different. The fact that pharmaceutical companies can advertise their prescription medications directly to consumers is quite unique. In other parts of the world, they either can't advertise or like in Canada, they can advertise the disease and mention there's a drug that treats it, but they can't mention the name of the drug, or they can mention the name of the drug, but not tell you what it actually treats. So here, our ads are allowed to be far more comprehensive in the information that's being given directly to consumers. That being said, of course, there are a lot of regulations. It's regulated by the Food and Drug Administration. And a couple of the key regulations to note are this adequate provision. That was something that was a rule that was put in place in the late 1990s that said that if the ads in a broadcast medium at least provided a website or a toll-free number or directed to, the consumers to a magazine ad that had more complete information, or even just said ask your doctor, that allowed the ads to be on broadcast on TV without having to provide that full extensive information about all the various risks that a drug has. And so that really boosted the continued rise in TV advertising within this category. The other main regulation is referred to as the fair balance doctrine. And so what that says is that within this risk information that is required to be communicated within the ads, it needs to be communicated in a manner that is relatively similar to the benefits information. And of course, that is purposely vague in the way that it's worded. And so there's a lot of research that has focused on trying to assess the degree to which the ads adhere to this fair balance doctrine, both explicitly, but more important, implicitly. You know, what are the cues that might skew the way that people are either interpreting the risk versus benefit information, or even being able to pay attention to versus being distracted as those different types of information are being provided. This is a category that continues to be a focus of controversy, with people on the pros side advocating that these ads are important because they can empower people to be more concerned about their health, to have better conversations with their doctor, to be a source of education so that they are learning about health conditions that they may not have realized they have. And so that can be important, again, for making sure that people are informed and motivated to talk to a doctor, that those who are already taking a medication might be, the ads might serve as a reminder for them to take their drugs. And so that can help with adherence. And that also, the ads, very capitalistic sort of argument is that because these companies are advertising when there are multiple medications that are treating the same condition, that can foster competition, and that would fuel greater innovation and actually potentially lower drug prices. On the con side, though, there's a lot of concern that these ads are misleading, that there can be a lot of room for misinterpretation of the information, that it contributes to our society's tendency to rely on drugs as a quick fix when there might be other sorts of treatments that are cheaper and safer. That if patients are going and talking to their doctor with this idea that they absolutely want this drug that's been advertised, and that they are asking for a prescription for that drug, that doctors, there's a portion of the time that doctors will just go ahead and give them that prescription. That could be inappropriate in some cases. And that on the flip side of the competition argument, that the fact that drug companies are spending so much money on these ads, that is contributing to the rising healthcare costs. The debate rages on, and so within this, I said, you know, my work has touched on a variety of different themes related to the way that emotion is getting used and what the effects of that might be on risk perceptions, factors of trust in this ad category, looking a little bit at how race has been represented in the ads and the presence of cues that would address stigma associated with certain health conditions. More recently, I've been looking at the use of narratives, storytelling within the ads, and starting to explore how that might be impacting the way that people process the different types of information in these ads. And I'm just starting to look at this topic of patient influencers. So on social media, the degree to which pharmaceutical marketers are starting to work with patients, influencers who have a following, and trying to understand, trying to, explore that for right now to better understand what the pitfalls, but perhaps also the opportunities of that might be in terms of more comprehensively delivering information about these drug treatments. But for today, I'm going to be focusing on a line of work that I started working on during my sabbatical last fall. That is still, as I mentioned at the beginning, very much a work in progress, still very much still underway. So I'll be giving you sort of a sneak peek to where I'm at right now with that. As a little bit of background to expound a bit on that introduction to this topic, I'm sure, given that we're in a presidential election cycle, there's a lot of talk about healthcare costs here in the US and how they are far greater than our peer countries around the world. And so here's some data related to that, pertaining specifically to spending on prescription drugs. And so this is one source of data showing that within this country, we spend about $1,200 a year per capita on prescription drugs. That's at the country level, which is greater than other countries in Europe. And another data point that supports that idea as well, that we are spending more on pharmaceuticals per capita than any other country in the world. And if we look over time, this is a really interesting graph, because what it shows is that, over the last 20 years, and could go back further, but within the last 20 years, that there has been this steady growth in how much prescription drugs are costing in terms of the prices that then relate to the expenditures on prescription drugs. What's interesting here is that, so this yellow line is total. The brown line is how much is being spent by insurance, and that includes both private insurance companies as well as government insurance like Medicare and Medicaid. If you look at this orange line here, that's what patients are paying out of pocket. And so what you see is that for patients, according to this on a whole, the out-of-pocket costs have not really increased that much, but it is the burden that's being taken on by insurance companies and the government. And the reason why that is insightful is when looking at this data from a survey that was conducted by the Kaiser Family Foundation in 2019, showing that a large majority of people do agree that prescription drugs cost too much, that it's unreasonable how much they cost. And yet, for about the same majority, they say that affording prescription drugs is easy. Now, obviously, there's a quarter of people here that have difficulty affording prescription drugs, and that is certainly a concern. But when talking about the rising costs of drugs, this is something that for those people who are insured, it's often invisible, that these costs are not something that are always clear, what is the true cost of a drug. And the reason why that's relevant is thinking about then the strategies that have been provided for addressing this issue. Because even if a majority of people are not feeling that pain within their prescriptions in terms of what they might pay for medications that they're on, given that there's a burden on the government, it does certainly show up in terms of tax dollars. And so in May of 2018, the Trump administration put forward a strategy for addressing this issue. And within that, one strategy was to be able to better negotiate drug prices. But a lot of the strategy relied on using typical market forces, market pressures to be able to address this issue, to drive down costs. And so that's how it then connects to the advertising. Within this one strategy of trying to create incentives for lowering the price of drugs, there is a proposal that the TV advertisements in particular would be required to include the list price of the drug, which the list price is what people would pay out of pocket if they did not have any sort of insurance coverage. So as long as the list price of a drug was $35 or more, and it was a drug that got covered by Medicare or Medicaid, so that's the large majority of prescription medications, that there would have to be a statement within the TV ads on the last screen of the ad at the end that would include the list price for a typical course of treatment, which would be like for a month dosage or a 3-month dosage. And this was originally put forward in October of 2018, and then it was finalized in May of 2019. And this proposal is not something new. In fact, as I was looking at some of the older studies that have been done on prescription drug ads that were conducted in the late 1990s and around 2000, when people were really first starting to do research in this category, there were some mentions of proposals, recommendations that the price information be included in the ads for greater transparency. And this is another data point from that Kaiser survey showing that 88% of people thought that this is a good idea, that the federal government requires these advertisements to include the list price of the drug. And this is a quote from Alex Azar supporting the idea of this, that if we want to have a real market for the drugs, why not have the companies disclose their prices in the ads too? That way consumers would have more balanced information and companies would have a very different set of incentives for setting their prices. So this is this indirect way of trying to drive prices down that really stems from an economical theory argument. So the idea that by providing this information about price, it would reduce information asymmetry. So meaning that this idea that patients don't have as much information about drug prices as pharmaceutical companies do. So there's an asymmetry there. Often people don't know how much a medication is going to cost until they walk up to the pharmacy counter and they're told, as they're being handed their medication, what the cost is going to be. And so by having this disclosure in the ads, it reduces that gap in knowledge. The other argument was that by providing this price information, it would motivate people to engage in comparison shopping. So if they see the ad and they see this list price, that it might motivate them to see if they could find a lower price alternative, another drug that might be more competitively priced. And that this sort of marketplace pressure would incentivize pharmaceutical companies to lower their prices, either to be competitive with other companies, or just out of pure shaming if they're having to disclose an astronomical list price and that they may not want to do that. That is the way that these proposed benefits were described. But there's certainly been a lot of concerns raised. For one point, that the list price is often not what people are paying, because if they have insurance or if there's been some sort of negotiated discount along the way, that they're going to pay something other than the list price. And there's a lot of variability in what a drug will actually cost to an individual. And so there's been points put forward that the list price, which is what was required, that it may not be fully informative. On the flip side, in terms of motivation, that to the extent that the ads do help to motivate people to go talk to the doctor and seek out a treatment, and that could be useful, that if the list price that they're seeing seems really high and conveys the drug as being unaffordable, that will discourage people from even having those initial conversations with their doctor. And also the concern that these ads are already so packed with information within the 1 to or even 2 minutes that they're on air, and that there's this great opportunity for cognitive overload, and that attention is often selective in this sort of context. And so would the price information even get noticed? Now, I will say that after this proposal was finalized, a federal judge did block this particular proposal because, on a technicality, that this was something that was put out by the Department of Health and Human Services. And what the judge determined is that the HHS did not have the authority to be putting forward this proposal. But again, it was blocked based on that technicality. But this is an idea that it's not brand new, it's likely to come up again. And so it's something that there needs to be some more data around this issue in order to guide these sorts of policies. And so that's where one of the projects that I've been working on related to this topic comes into play. So in the last year, I've been working with Eileen Holland, who's at the School of Public Health here at Temple, and she has a health economics background. So we're putting together our economics and our communication expertise to work on this. And so we've started out with an initial experiment. And what we did is we took, for the sake of generalizability, ads for 3 different medications, a medication treating deep vein thrombosis, which is a heart issue, diabetes, and rheumatoid arthritis. And so those vary in terms of the degree to which they're life-threatening. They vary in terms of their incidence rate within society, and they also vary within what the price of the drug is. And for each of those health conditions, we also we had a control condition where no price information at all was included in the ad. We had the condition where the list price was given, which is what the proposal was recommending, the policy proposal. And then just in order to see if some additional information was given, would that make a difference? We had a condition where it provided the list price plus what the typical cost was to individuals. And through a grant that we applied to, we were able to access a panel to collect our data. And this was collected near the end of last year, so before the pandemic hit, which has changed the nature of the ads in a certain way. We used existing ads. and edited them down so they were all trying to control for the different ad related variables to make sure they were consistent length, that they were similar in terms of the types of information that they were conveying. And here are screenshots then of that last screen where we included then the price information, edited that in. And so you can see that we kept it pretty much as it was in reality, just to have that external validity. So they often end with the brand name of the drug and the logo. And then this is, in all these cases, this is the condition that gave the most information. It has the list price. So like for the Invokana ad here, it says the list price for a 30-day supply of Invokana is $390. If you have health insurance that covers drugs, your cost may be different. Typical cost to patients is $40. Initially, when creating these ads, this last screen is only on for about 2 seconds. And that's really quick, especially given, I mean, this is a lot of information. There's complex right here, even just on this last screen, which is what the proposal was saying this price disclosure would rely on. So we did extend it to 4 seconds, which is still pretty quick. But, you know, that is something, again, thinking about the realism, if this really was just to be provided on the last screen, people would probably be exposed to it for an even shorter amount of time than what we had in our experiment here. In terms of what we were measuring, so we're hitting on trying to assess, at least at a basic level, these different arguments that were for and against this idea. So in terms of that information asymmetry argument, we had an item in there where people could express just at a perception level whether they perceived the ads were more informative if that pricing information was mentioned. We also asked them what they think it would cost if they were to have to pay out of pocket, or you know, what they thought they would pay out of pocket for the drug. Their behavioral intention. So again, that sort of likelihood to ask a doctor for a prescription, to tap into that motivation to seek treatment, as well as how likely they'd be to compare the medication on the basis of price. So that comparison shopping argument. We also wanted to see, you know, did people even notice the information in an explicit way? So ask them yes or no, which of these various different types of information they saw, and embedded within that was price, and then this a notice of how my costs might differ from the price provided. And then also to look at perceptions of the drug, perceived effectiveness, safety, and of course what we are most concerned with, or most interested in, was that perceived affordability of the drug. And so here's some of the results that we've been able to suss out so far. So here's that recognition question in terms of, did you notice, what information did you notice in the ad? Within this, the yellow bar is the control condition that had no price information. The orange bars are where the list price was given, and the brown are where it was the list price plus that typical cost. And so we do see that compared to the control condition, both of the conditions that had some sort of price disclosure, certainly the number of people who explicitly were able to say that they saw price information or a cost range being given, it did significantly increase. So that's good. We would hope that if nothing else, more people would say they remembered seeing that information. What we do see, though, is that it is far, the number of people who were shown that information, who noticed it, it was far less than these other categories of information, and the side effects and the benefits, the indicated health condition. I will say there are some foils in here too that weren't actually in the ads, like prevalence. That's very low because that wasn't actually in the ads. But you know, so yes, there's some indications that people recognized it, but not to the degree of other information in the ad. In terms of that perceived informativeness level, there was a tick up in people who saw those price disclosures, did overall evaluate the ads as being more informative. This was particularly the case for that rheumatoid arthritis drug when they were shown the list price. And I didn't point it out before, but on this next screen, you might see why. The list price for the diabetes drug was $390. For that deep vein thrombosis drug, it was $250. For the rheumatoid arthritis drug, the list price given was $2,680. So that's a lot. So it's not surprising that, if anything, that would be what would capture attention more and be seen as an important piece of information to be given. Now, this data here is showing that estimated price, so asking people how much do you think you would pay out of pocket. And in the control condition, they were just giving a guess based on what they thought it might be without having any information in the ads. We do see that in the list price, that estimated cost does go up. It is elevated. It's still far below what the list price would be, but of course, there are a lot of different considerations in terms of what someone thinks they might pay, you know, compared to that list price. We do see this pattern overall, which is responsive to the information that was being given, that the estimates were highest when just the list price was given, and they did come back down when that typical amount was shown. So again, that does show some responsiveness to the information that was being provided to them. Now, you may notice that that pattern does not hold for this RA drug, which, again, the typical price was $885, which is still really high. When we filter this data, though, by those who explicitly recognize seeing a price, then even in the RA condition, we do see that similar pattern, as well as just overall the cost and the list price condition being that much closer to what the list price was conveyed. In terms of perceptions, we did see that when the price was disclosed, the drug was perceived as less affordable compared to the control condition. And in particular, with the diabetes and the DVT drug, that decrease in perceived affordability was primarily just in that list price condition, because the typical price was pretty similar to what they thought the drug was going to cost anyway when we saw that control, the control condition. For the RA drug, again, even that typical cost was pretty high, so that affordability remained lower compared to the control group, even when that typical price was given. Now, behavior tells a slightly different story. So that argument that seeing the price might motivate this likelihood to comparison shop by price, we did not find any evidence for that. We also, at the total level, did not see any of the effects of the price disclosure on their likelihood to ask a doctor for a prescription. There was some stronger effects when we did filter by those who explicitly remembered seeing the information in the drug. And in that case, particularly for that RA drug that was super expensive, that did have a significant reduction in the likelihood to ask a doctor for a prescription for that drug, and that effect was mediated by the reduction in perceived affordability. So we have more to dig into in the data that we've gathered, but based on this, again, top line level, what we can assess is that yes, there is some evidence that there's a reduction in information asymmetry, that people do seem to be taking in that information and incorporating it into their perception of informativeness of the ad and their estimates of how much they're going to pay. It does not seem to be translating into this likelihood to comparison shop by price, which is just such an interesting and strange idea to me, quite personally, to be thinking about a discussion around prescription drugs that would resemble a typical consumer product of this idea of comparison shopping by price, because there are so many different factors and people tend to prioritize, is it going to be effective? And then the second question is it safe? And then price is down the road. And so based on that, we don't have evidence about the list price not being informative. Although I will say that there are some kind of below the surface level, we did have an open-ended question that asked them to explain a little bit more about why they gave the estimated price that they did. And you know, I think that we need to spend some more time looking at that, but there does seem to be a lot of questions that have been raised in terms of, well, I would need to talk to my insurance company a little bit more, or still even with the price information, kind of inferring from other cues in the ad what they might be spending. And so I think there's a lot more to dig into this particular point. But so far, we'd have to say no, based on the data we've looked at. And this reduced motivation to seek treatment, I think, you know, it's sometimes. So right now, what we can see is that those who were most likely to notice the information also adjusted their likelihood to seek treatment if the drug was above some sort of threshold in terms of the price of it. And that selective attention, so that relates to, you know, how many people did say that they were noticing the information. While it did respond to when the information was being given versus not, you know, it was still a minority of the people that noticed this information. And I put a maybe here because, you know, to what degree is that based on cognitive overload versus other factors? You know, this information is not something that, you know, list price has not commonly been conveyed in these ads. And so something to consider is whether or not this information has been incorporated into the schematic approach to processing these ads to the same degree that the risk and benefit information has been. Which actually brings me to then another study that I've started up based on this one, to want to be able to take a step back and see to what degree has cost information, any sort of cost related information been included in these ads. It's something that while there's been a lot of research on prescription drug ads and a lot of content analyses, it's just, this is not a topic that's been of great focus. And, you know, thinking about how people might be processing these ads and the degree to which they weigh pricing information versus other types of information in their decision making. You know, I think it's important to look at how sort of the degree to which this information has been conveyed through the ads. And so, you know, the way I'm thinking about this is from a priming perspective, with this idea that information cues can influence what we even consider to be important factors in our decision making, and cues that are present that much more frequently and that much more saliently then tend to get more prioritized and become more top of mind and more accessible when we're engaged in a decision making process. And also just shape expectations for not only what we expect to see in the ads and how we're going to process a particular message, but then also how we are evaluating that information. And so I've launched a content analysis to try to be able to look at this over time and to see what are the different types of cost cues that have been included in these ads. And cost cues can include, as I've listed here, the price of the drug, comparison of whether the drug is more or less. Usually it's going to, if it's going to be advertised, it's going to be trying to make an argument that it's less expensive than a competitor. Information about patient assistance programs. So this is this whole other category within this area that pharmaceutical companies will offer these sort of rebates and discounts as a way of reducing the price in a kind of a back channel way, as well as then, much like there's adequate provision for directing people to more information about the risks of a drug, the degree to which the ads are providing, directing people to additional sources for information about the costs of a drug. And there has not been a lot of research looking at this topic. Some quite dated work looking at magazine ads showed that through the 90s primarily, there was a very small to zero proportion of print ads and magazines that included any sort of cost-related information. More recent studies, relatively more recent studies looking at websites did find that a majority of the websites had some sort of cost information. Those studies, though, were focusing on like coupon offers and discounts. That doesn't comprehensively cover all the different types of cost-related information that can be provided. So, you know, because this proposal sprung up in the context of TV advertisements, and TV still gets by far the largest amount of investment within these direct-to-consumer prescription drug ads, I wanted to be able to look at this within TV ads. And so I've started with a set of ads, again, to be able to look over time, a set of ads that were gathered systematically from 2007, 2016, and then 2 periods in 2019. And if you were to ask, why have you picked those years? Well, that's because those are the years that I happen to have available from previous content analyses that I've done. So I'm starting with what I have already, because TV ads are something that it's not like print where there's a ready access of magazines that are in the library that you can look at. It's a little more ephemeral. And so to balance that out in a still imperfect way, I am also tapping into a database that's available that has been collecting ads between 2002 and 2019. It's not necessarily systematic, though. It's gotten better over time. But I'm also going to look at that as just to have a separate set of ads to see if there's some cross-validation between these 2 sets of ads that were gathered in different ways. What I'm looking at within the content analysis, and shout out to Yu-Hei Su, who's been helping me with coding these ads, is that, you know, I'm looking at if there's a price that's been communicated for the drug and various combinations of how that price might be conveyed. The degree to which these patient assistant programs are being communicated, and that often are posing either a savings amount or talking about a free trial, or even a vague statement like, you know, if you're having trouble affording your medication, AstraZeneca may be able to help. And then this additional reference, which is actually something that in April 15th of 2019, so right when I was in the midst of gathering ads from 2019 for this, that pharmaceutical companies, as a process of self-regulation, said that they would start including a link to a website that would give more information about the cost. And so since that happened right in the midst of this, I figured, all right, well, let's see how quickly they responded to that. So that's what this additional reference is. related to that sort of priming argument and the salience of the information being important, I've tried to capture that in a few different ways in terms of the placement, how early versus late in the ad is it communicated, when it's in text, where is it on the screen? If it's, is it just communicated in text, or is it also spoken? And is it spoken by just a voiceover or by a character speaking to the screen? Those all influence the saliency of that information, as well as then taking some other more qualitative notes on, for the text, what's the background color? What's the general size of the text? Is it a background that's dynamic or is it static? Again, to sort of speak to how easy it is to recognize this. Where I am, we're done coding those ads that were systematically coded or systematically gathered, but I haven't had a chance to fully dig into it. But what we can see is that comparing 2007, 2016, and those two periods in 2019, there's certainly a steady increase in the degree to which cost-related information is being included in the ads. These are percentages, so the percentage of ads that included any type of cost-related information. There's one ad so far that was from the very most recent set that gave an actual drug price. That's just a straight up price, not something that's part of a patient assistance program. And it's quite extensive. This is for Xarelto, and it's saying the list price, $448, but then it also talks about what the typical price is, that it ranges from $0 to $47. And so this is very comprehensive, and so far what we've found, very unique, that this degree of information is being communicated. In terms of those that patient assistance information and the additional reference information, those also are information types that have steadily increased over time. And that additional reference, it did go from February of 2019, 67% of ads had a link to where people could find additional information about cost, and that went up to 92% in May, right after that self-regulatory measure. So there does seem to be some effort to at least meet that minimal action of saying, well, here's where you can go to find some additional information about cost. There's so much more to be able to look at, somewhat, within the data that we have been gathering, that we can look at more, and then other studies. As you can tell, this is very much guided by policy at this point, and so from here, there's opportunity to do more theory-driven work to better try to explain some of the patterns that we're seeing. And so being able to look into that propensity to notice the price information, and how do all the different factors related to motivation and ability, both in terms of the way that the information is disclosed within the ads, as well as characteristics of consumers, and the factors that may influence whether they're likely and interested and able to process this information about price. Noticing it is sort of a minimal outcome. How well they actually comprehend it and interpret that price information is a whole other category. As I said, right now we've just barely touched on that idea of, well, are they adjusting their estimated price, estimated cost? But there's a lot more to get into in terms of how are they really thinking about that information, and potentially factoring that into any sort of decision making or discussion with their doctor. That's all more explicit responses. but in a more indirect way, to what degree does that price information sort of increase how much people are thinking about cost when considering whether or not to pursue a prescription drug? And even what I tend to think of as that much more interesting, what sort of inferences might they be drawing from price? So in the marketing world, price can often get equated with quality, and even within prescription drugs, sometimes drugs that have the most severe risks are also inferred to be the most effective, because the idea is that if they have really great risks, they also must be really strong, and so they're going to be more beneficial. Does this translate to price? Is a high price drug considered to be more effective? We have a little bit of data on that. We haven't really looked at that yet, but that would be an important implication to be able to explore, as well as from a perspective of sort of attribution and transparency. Does including price information sort of instill this idea that drug companies care about me and want to give me more information, and so that enhances this perception of goodwill? Yeah, we'll see. I'm excited to move forward and build on this from where I am, and to hear whatever questions and ideas you may have. So that's it for me. Thank you so much. I'm going to stop sharing right now so that I can.
Thanks, Jennifer. We've got some time for some questions.
Ed, I see you raising your hand. I wasn't sure who's monitoring this or who's moderating this. I guess I will.
Okay. I have a couple of questions. The first thing is, I don't know if you mentioned this, but one of the things that are almost automatically comparison that some people make is comparing the cost of the drug with the generic version of the drug, if it exists. Yeah. And I think if you gave people like a generic alternative, or proposed a generic alternative, that might have made a big difference in how they looked at the cost in that sense. That's my first comment. And the second comment is that one thing that I think might be helpful to evaluate what's going on is to consider things about what is the illness that, I know you considered 3 different illnesses, but how much pain is associated with the illness, or how much disability is associated with the illness. Because I can imagine that if the pain is substantial or the disability is substantial, they may be more likely to be accepting of the higher price, and they might also think that a lower priced item may be less effective. They may assume it's less effective because it's lower priced, whether that's true or not. So those are questions I think that might be interesting for you to attach as you consider this lifetime task of figuring out about drugs. But I really appreciated your presentation. It's very, very informative.
Yeah, thank you. And yeah, those are very good points. And particularly with the nature of the health condition, research that in other contexts compares different health conditions, yeah, results can really vary. And I have to point out too that because of the nature of the grant that we were given to access this panel, it had to be sort of a general population approach. So we did ask if people had the particular condition, but it tended to be too much of it was not a substantial number of people. We did, do some comparisons, and so far I found that there hasn't been a large difference in effects between whether they actually have the condition or not. But that would be something that is a limitation of what we've looked at so far, that these were really, primarily a general population. To your point though about the nature of the severity, or whether a condition is symptomatic versus not, it certainly impacts the sort of the concrete experience and the motivation for what the benefits that people are seeking. That can certainly change the calculus of how people are weighing the benefits versus the risks, and now the cost in terms of a financial sense. Yes, thank you for for those comments.
Jennifer, can I ask a question? You had talked about behavioral intentions and in terms of price disclosures, and your research is framing people as being consumers. And I wonder if you've thought about framing them as citizens and asking those questions in terms of how price disclosures may lead to some sort of political acts afterward. In other words, in terms of, you know, do they reach out to their congressman? Do they change their voting behavior? Do they do something that sort of is a more political approach to changing the way in which pharmaceutical industries interact with patients, consumers, but not so much from a consumer standpoint, but something in terms of, you know, how they see that fitting into the political landscape?
Yeah, that is such a great point. Yeah, of course, this is focused and stemming from this argument that's very much looking at the influence on people as consumers slash patients, which I have to say that when I started looking at the policy proposal around this and just the language of it, you know, a big critique of this ad category has been that it does treat patients as consumers, and that's seen as inappropriate in this sort of category often. And so here was a policy that was really pushing that idea of trying to encourage patients to act as consumers. But right, that's a whole other set of consequences in terms of thinking about it, going back to that graph of how so often the true cost of drugs is hidden for the majority of people who are not having to pay that full price. And so that disclosing the list price could exert political pressure and political activism. That's wonderful. I'm gonna write down that idea for sure. Thank you.
Others?
David.
I have a question,
Yeah.
real fast. Hello, can you hear me?
Hi.
Sorry. Like when companies like Moderna and like Johnson and Johnson, like I know that a lot of companies are working on like COVID vaccines and stuff like that. Is there like a standard like market price for something like that, like an actual like a worldwide pandemic kind of like drug, something like that, or do they just make their own prices?
So for that particular unique circumstance, I'm not sure. I can't answer that. I can say that for drugs in general, the way that it works here in the US is that essentially drugs are priced at what the market will bear. Now that being said, it's much more complex than that. And so, you know, in most of the rest of the part of the world where there's a single payer system, the government engages in negotiations and really limit what drug companies can charge for their medications, and also the government, and particularly for the medications that the government will pay for. So certainly people could go outside of that system and pay out of pocket for a drug that's not approved by the government system. You know, here in the US, again, yeah, drug companies, they sort of set a price, but even within the list price that's set, there are these pharmacy managers who will work out in a very individualistic way for their particular system what they're going to pay and what sort of discounts they're going to require and request from pharmaceutical companies. And so that becomes a sort of backroom process where then the costs of drugs get set.
Yeah. I was just
There's
saying
no
because
standard.
yeah, that's because I remember that guy. Who is that guy? The pharma bro, Selecki, or what was his name? I forget.
Yeah, and I forget his name too, but yeah.
But like, would a vaccine, like something like that, would that be considered something like they have to like keep it at a certain price rather than like boost it up like a crazy percentage increase or something like that?
Right.
Yes.
You, you would hope so. Yeah. Okay.
Yeah.
Thank you, Andrew, yeah, for posting the name. I'm not sure. The short answer is I don't know, and we'll see.
All right. Thank you.
Probably have time for one last question.
Hi.
Avery?
Yes. Hello. Hi, Jennifer. I had you as a professor a couple years ago.
Okay.
for
Hi.
advertising. But my question is in regards to maybe looking at as well, maybe talking with doctors to see what their opinions are on these advertisements as well. I know I work with hematology and we deal with a lot of deep vein thrombosis patients.
Okay.
But I think it would be interesting to see how often they're being asked about this by consumers, because I know that they have, you know, doctors know what they're talking about and patients may want a specific drug. However, if depending on the other medications they're taking, they could also be denied by their doctor. But again, I just think that would be some other portion, because I know, again, you're focused on the consumer, but I think doctors have an idea of what drugs are good and which ones aren't, and especially the ones that are being shown on television.
Yeah, definitely. And thank you for that point. And that is, there is a set of research that has focused on doctors in terms of their opinions, in terms of their patient-provider interactions. It's not where I've gone with my research, but it is something that, you know, and it seems that doctors are really split. And sometimes it's generational in terms of how much in favor they are with the ads, whether they see it as a good thing, because at least it's getting the patient into my office, and then maybe we can find some other issues with them, you know, versus having, you know, having the ads create all this misinformation that they then have to correct, which is seen as annoying, especially in this context where doctors they only have so much time with each of their patients because of the insurance structure. And so what would be really interesting in this context is to see, you know, the research that I've come across that's looked at that particular angle. I don't think it's focused on how much do patients bring up the cost of a drug within that conversation. Again, it's often something that people don't even have an awareness of it or think about it until they actually go to pick up their prescriptions. And yet it's such an important piece of the conversation that really enhances that relates to the feasibility of whether or not somebody can take a drug, especially for those depending on what their insurance is. And what was interesting is that, so first off, doctors, of course, are getting their own marketing at them continuously. That $6 billion figure that I gave for how much gets spent on consumer marketing is a fraction of the amount of money that gets spent on marketing to physicians. I think for physician-directed marketing, it's somewhere around $15 to $20 billion. And Avery, you're nodding your head saying that. And so some of the ads in that additional reference for information about cost, some of the ads did mention talk to your doctor about, now it wasn't saying, you know, to engage in a good discussion about, you know, weighing the cost of this drug versus its potential benefits. It was saying talk to your doctor about a free trial. So that sort of idea that doctors have these samples that they can give, or that sometimes the rebates are given to the doctors to hand out. That is part of the marketing structure. So I mean, there's that part to explore, as well as then, yeah, how much are patients, expressing concerns about the cost or asking about the cost. And how much are doctors equipped to answer that question though? Because again, it can really vary and doctors may not have that full information.